Good morning, everyone. We're going to go ahead and get started at 6:30. We have a lot to cover today. I'm going to have Dr. Bolger come and introduce us.
Thank you so much. And we're really happy that you could all join us for the special grand rounds. I think you'll find it very interesting and maybe a little scary. But we have really three great speakers today. I'm going to introduce them briefly and then turn it all over to them. Dr. Bryce Robinson, who I think you all know is professor of the Department of Surgery in our division and has been the medical director for our military-civilian partnership program since we started. And so he's going to give a good overview of the program for you, the history of it, intent of it, and where we are at Harborview with that program now. And then we have our two embedded military surgeons. We have Lieutenant Colonel Alex Malloy and Major Dan Roubik, both of whom have been with us now for several years. They're fully embedded at Harborview. They're members of the faculty, both at the assistant professor rank currently, and have been really terrific partners with us and have really highlighted the value of this partnership. And they're both going to speak from their perspectives about different components of the partnership and then where we're headed. So I'm going to turn it over to them. They have a lot to cover, and I think you'll find it really interesting. So thank you for coming.
Okay, can everybody hear me all right? I had to put my glasses on for this one, sorry. Well, anyways, my name is Bryce Robinson, and as Dr. Bolger alludes to, I'm the medical director for our military civilian program at Harborview. And really today we're going to talk about the partnerships between the military and civilian centers, and specifically those at the University of Washington. I have no disclosures. Everything you're going to see today is from us. As much as the military wanted to address it, but these do not reflect the opinions of the Defense Department. And really, I have a personal disclosure and appreciation. I've never worn the uniform. I got to Boy Scouts. That's the farthest I got. And I have a great deal of respect of many of my mentors, my colleagues, research colleagues, and just people that I've worked with over the years have really influenced the practice of my medicine and my trauma care. And I'm deeply thankful. So thank you for your service. Overall, our goals today, we're going to talk about the history of military-civilian partnerships within the context of the University of Washington. We're going to identify the mission of our military members assigned right now, and then we're going to assess the current and future needs of our partnerships in the context of large-scale operations or disasters. Okay, so I'm going to start off, and I'm going to talk about the history of these partnerships, and again, talk about our program at Harborview. From the Revolutionary War to about World War II, military medicine was a volunteer sport. You would enlist, you would perform your surgery or medicine, and then you would get integrated back into the civilian sector. And things that you learned in theater were integrated into your civilian practice. And things that we do every day that we take for granted that are commonplace were actually very novel battlefield care items, but again, integrated back into that civilian sector, like triage, wound care, modern anesthesiology, blood transfusion. These are all military practices that got perfected in theater and then came back into the civilian sector. The problem that military medicine unfortunately suffers at times is this idea that we build up and we create this large infrastructure for each one of our conflicts. But after the conflict is over, there's a rapid decrease in the capability of military medicine and the expertise of those that are still there. And this is known as the Walker dip. And this happens after every conflict, and it's multidimensional. You can see that it's oftentimes loss of leadership. The military's fiscal constraints are decreased after each conflict, so the resources are just less. There's this idea of a garrison mentality, or just focusing on the things in front of you and not bigger picture things. And then finally, leaders in military medicine go on to different things. There's a loss of institutional experience and culture that leads to this gap of capability and experience. And this was really seen at the time of the Gulf War. In the background, before the lead up to the Gulf War, military medicine had significantly grown to have military hospitals on military bases served with military surgeons. And that was the infrastructure to prepare for conflict. But after the Gulf War, both our combatant and our military commanders noticed there was a huge drop-off in the expertise of those surgeons and medicine performers in theater, and they quickly realized that they needed to investigate and understand why. And so they worked with the Congressional Budget Office to develop a report with multiple recommendations. And I think one of the most damning things in that report is the idea that military medicine delivered at a base does not align with what is seen in theater. Only about 5% of diagnoses seen at a military hospital align with what's seen on a battlefield, whereas in civilian urban trauma centers in the United States at the same time, 98% of those diagnoses align. So clearly the experience was not in the military hospitals, but was in those civilian counterparts. Fast forward to, again, the 90s and the 2000s, at the same time these gaps are being cataloged and identified, there was a huge increase in urban violence pandemic. And so urban trauma centers were seeing multiple gunshot wounds over and over again. And it wasn't just regional, it was throughout the country. The military was aware of this and really wanted to leverage that experience. So in that time period, the Army, the Navy, and the Air Force approved for the first time their own military fellowships to go into the civilian sector. And so that's how they wanted to train their future trauma surgeons, not in military hospitals because of those gaps I just described, but because of the experience seen at these urban centers. Brooke Army Medical Center in San Antonio became the first ACS verified military hospital within their integrated regional system. And that's kind of a big deal. Now you have a military hospital participating in the civilian regional trauma care. And so they saw not only civilians, but they also saw military people at the same time at this one large military trauma center. So kind of a big deal, novel experience. And then after that point, things really started taking off with the growth of military-civilian partnership. These partnerships come in about 3 different flavors, and this is just broadly speaking because there's many different kinds. But for the purposes of this talk, they come in kind of 3 buckets. The first one is the integration of facilities into the civilian trauma system. And so we have that right now. So Madigan Army Medical Center is a level 2 trauma center in Tacoma. They see both civilian and military injured folks. They participate in our system like anybody else. There's a collaboration of providers, and sometimes it's a little bit more direct or indirect. So the first one is this collaboration where military members will split their time. They'll be assigned to a military facility and a hospital, but they'll also cross the street and participate in the civilian sector in these university hospitals. And then finally, and probably the most important to today's talk, is this idea of being stationed and embedded. So these are military providers deployed into a civilian center. They have that sole responsibility, and they integrate directly into divisions and departments, into the infrastructure of the hospital, but also maintain their military expertise. In 2016, it really started changing the way we think about these partnerships. The National Academy of Science and Engineering and Medicine released their Zero Preventable Deaths. And this is a really kind of a big seminal paper for the trauma community because it really highlighted our gaps, but a pathway forward to improve not only the civilian sector's trauma care, but the militaries. And with it, there's multiple recommendations of how we get to that higher plane. But for this talk, it's really the idea that the Secretary of Defense should pursue the development of integrated permanent joint civilian military trauma system training platform. So the National Academy of Science really called out the idea of creating these partnerships and maintaining them and supporting them because this is where that experience is going to be gained. There's pros and cons to having embedded personnel within your civilian sector. First and foremost, we are very high volume. Our volume is 5 times what a military hospital would see. And there's no doubt that our acuity aligns with what people are seeing in the battlefield. There's a team mentality. The people in front of me are on my team. We take on a Friday night together. They participate in the hospital. Again, it's this teamwork and this regional focus of how we can improve care for all of us. They have a single center focus. They don't have to worry about this exercise or going down to Tacoma to do this thing at Madigan. They're at Harborview, and their focus is with our patient care. There's bidirectional learning. We learn from them when they come back from deployment, and then we teach them what we practice in our institution. Lots of collaborative research. I'll be the first one to admit some of my first grants came from the DoD because of collaborative mechanisms like this. And then finally, it aids in our civilian work shortages. These are very busy, very smart, very capable people integrated into a busy system that can help us with our workforce issues, but also can help us should a mass casualty care scenario evolve. It's not all good. There are some challenges to these partnerships. The first is they will leave. They are here, but at a certain period of time, they will be deployed, and deployments can take several months. Again, kind of intensifying some of our civilian work shortage at moments. The biggest concern from the military is this idea of their own reduced ability to care for military beneficiaries. And there's about 9 million military beneficiaries within their own health system. And if we're taking surgeons and doctors and we're placing them in the civilian sector, what's going to happen to those beneficiaries? How are they going to get their care delivered? Credentialing and licensure can be a challenge. We've doubled the bureaucracy. I'll be the first to admit that, working with the University of Washington can be challenging. Work with the Army. That's even more challenging at times, as we saw yesterday at 3 p.m. The cost of living is different. Living in Seattle and being a surgeon in Seattle with a salary of a military partner is much different than if you're on a garrison or a base. Just the economics don't favor us at times. There's complexity with RVUs and billing and how do we capture them and how do we monitor their work? And if we're giving up time for them to participate, how do we make this all work within the department and division? They can't provide billing care to insurance of the military, TRICARE, so that's complicated on the back end. And then finally, there's an administrative function. The Army wants numbers, they want records, they want case logs, they want billing. It's a lot of things that they demand to maintain the program. And so that administrative burden falls on us. But we were lucky. In 2019, Congress listened to the National Academy of Science and they enacted into law the Mission Zero Act. And what the Mission Zero Act allowed us, about $11.5 billion to carry that administrative burden so that we could have these partnerships. Now, the bill's a little bit goofy, and we should talk about it, because I come back to it at the end, is that the bill is not a Defense Department bill, it's not a military bill, but the bill that funds this program is actually a Pandemic and All Hazard Preparedness Act. And it was administered by HHS, and it goes through ASPR. So it's a little bit challenging to understand, but again, this is not coming from the DoD, this is coming from HHS. At Harborview specifically, we really started the conversations with the Army after the Mission Zero Act. So with funding capable, the military, specifically the Army, really started to spin up this idea of how can we create programs, partnerships for the sustainment of skills. And the Army Surgeon General of 2014 came up with really two big programs. First off was the SMART program. This is mainly for enlisted personnel, where they would be integrated into civilian centers for about 2 weeks to learn some skills. And these are mostly medics and scrub techs. They wanted more experience, they wanted more higher buy-in, and so that program occurred. Unfortunately, it has this been closed. More important to this talk is the AMCT grade program. So this is the Army Military Civilian Trauma Training Teams. Now, these are officers, so nurses, surgeons, doctors, CNRAs, same idea. They get integrated into civilian centers, but they're there for 3 to 5 years. So they're here for a longer period. Harborview's had a longer collaboration military than just the 2019, 2020 period of time. Since 2007, the University of Washington and Harborview has seen different trainees from Madigan Army Medical Center and JBLM. To count, there are 11 ACGME programs that send residents and fellows to the University of Washington to gain that experience. Specifically for the Department of Surgery, we had 2 surgeons in 2019 that were assigned to the Joint Special Operations Command. So this is special ops, either trauma surgeons within their program, and they were with us, but they were more collaborative. They would spend time at Harborview and they would spend time at Madigan Army Medical Center. And so in the background with the Mission Zero Act and understanding what worked and what didn't work for our program, we were able to codify an MOU with the Army in the summer of 2021 between the Office of Surgeon General and UW Medicine and the CEO of Harborview to have our AMCT3 program integrated into Harborview Medical Center. And this is part of the 250th Forward Resuscitative Surgical Detachment. Well, what is this Forward Resuscitative Surgical Detachment? These are specialized surgical units designed for damage control surgery and damage control resuscitation. The goal is to get these units close to the point of injury within that golden hour. They're small, they're mobile, they can set up within 90 minutes. They have the capacity to have 4 operating rooms to do 30 cases within 72 hours and have the ability to deliver critical care after those interventions are performed. The FRSD model has multiple operations they can have, but you can see if you look at these operations, thoracotomies and shunts and fractures and fascia. These are all things that we do at Harborview every single day. And so the alignment between the skills required at the FRFD and what we're providing at Harbor really, really accentuated that nice partnership, that nice collaboration. When we look at the FRSD model and the people that they send us, it's like a mini hospital. So they have a component devoted to emergency room care, nurses and doctors. They have a component that's, again, devoted to surgery, orthopedic surgery, general surgery, and techs. And then that last component, that last mini hospital, is that critical care unit. So ICU nurses, and the ability to deliver care for them. Our AMCT3 program is one of 8 nationwide, and really these have grown since their inception in 2018. With these 8 programs, we now have 50 deployed officers throughout the country at different sites doing the things that ours are doing at Harborview. And you can see that we are part of a list of some impressive centers: University of North Carolina, University of Chicago, Vanderbilt. These are all really high volume, busy centers that allow our military members to be spun up. Again, to decrease that idea of the walking tip. There are expectations. The Army is very, very clear with what they're trying to gain, the experiences of these personnel that are deployed. And each individual that comes to us has individual critical task lists of procedures that they want them to see, and then they count them. They really want to see these and count them. And then for us, there's a lot of reporting. There's quarterly pushes of billing data. We just had to do that from UWP last week. There's multiple Mission Zero action reports that we need to provide, case logs. The list goes on, but there's a very careful watch to make sure that these deployed members are getting the things that they need to be ready for combat. We can't give it all. If you look at the list of things that they need to do, canthotomies and craniectomies, those are pretty unusual for a general surgeon in a civilian sector. And so we acknowledge that. So we were able to leverage the WISH lab at Harborview to gain those skills. And so last year, the entire 250th came up with Tacoma, and we're able to do a team training exercise, the leadership structure, et cetera, but also to perform simulation to fill in some of these gaps. And to date, the Mission Zero Act has been really important for getting these embedded programs established and maintained. And so today, there's about 25 programs. There's 10 within the Army, 8 within the Navy, and 7 within the Air Force. And there was a paper in 2022 that came out that said that there are about 87 unique partnerships as a result of the Mission Zero Act. So it's really the lifeblood of this program to maintain it and to hopefully maintain the future. But that's unclear. Like a lot of things in Washington right now, we're not really sure where the funding is going to come from next. If you remember, the Mission Zero Act was signed into law in 2019. It expired in 2023. And unfortunately or fortunately, we were able to get emergency funding for 24, and our 2025 funding just landed. But after 2025, we're very unclear of where this is going to go. Right now, there are 2 bills making their way through Congress. The first one is the House to actually separately fund these programs. And then in the Senate, there's a momentum, at least in committee, to reenact the Mission Zero. But much like everything else, we don't know where this is going to go. The American College of Surgeons is very much interested in maintaining these things because there's benefit for not only the college, but also for the trainees here abroad. So just to keep that in mind, and that's the QR code for Surgeon's Voice where you can lend your support. One summary for our talk: the military-civilian partnership within the University of Washington have a long history, and you can see that we really provide a unique experience for battlefield medicine preparation. And then finally, members of the 250th Armored Forward Surgical Detachment, the FRSD, those are our AMCT3 members embedded at Harborview. All right, well, I want to turn it over to Lieutenant Colonel Malloy to talk about the mission.
All right, thank you, Dr. Robinson. I'm Colonel Malloy, or Alex, for those of you who work with me. I also have no disclosures. This is the standard that the military. Objectives here: we're going to identify the mission of our members here, primarily what makes Ruth and I are here for, why we're here, for the tangible benefits, and give you a little show and tell about what it's like to. What's life like as an Army trauma surgeon? You can Google this. I asked ChatGPT to find this out a little bit. Just looking at the Army in general, there's about just shy of 1 million people in the Army alone. We're not talking about other branches. But there's a good chunk of active duty and another good chunk of National Guard and reserve. So something you can't find on Google or internal. There's about 200 to 300 Army general surgeons on active duty. This includes trainees, residents, etc. And there's anywhere from 200 to 400 reservist surgeons out there in the world. So how many trauma surgeons are there? It's a very small world being a trauma surgeon in the Army. There's anywhere from 30 to 50 at any given time. That includes fellows. We're not average, there's about 35 of us. We basically all know each other. We talk, we collaborate, we put our heads together. So, being 35 trauma surgeons for 950,000 people, that's a ratio of 1 to 27,000 service members. So, yes, we fully rely on our general surgeons in times of war, and they can act as trauma surgeons, damage control surgeons, but we're sort of looked at as the experts. So we really need to maintain our skills to be able to take care of people that are injured. So our Army code is 61 GLA like 4. That's rather obtuse for this talk, but you may see it referred to in some of the slides. We are the experts in damage control and resuscitation. We are highly specialized. We need special opportunities to hone our skill to maintain them. That's one of the reasons that we're here and military civilian partnerships created. We're the unicorn. So in the Department of War, formerly Defense, the only level 1 trauma center in the entire military of all branches is Brooke Army Medical Center, which Dr. Robinson referred to, which is in San Antonio. And both Major Roubik and I are products of that fellowship there. They see about 4,000 trauma admissions annually. That includes civilians. It's a joint base with the Air Force. So, as mentioned, there's 35 trauma surgeons in the Army. Well, there's about the same amount in the other branch. So you can imagine that the cadre is pretty saturated. So, with 40, potentially 40 plus surgeons there, you're not getting a lot of opposite side. And that also, not takes into account that there's a residency there for surgery as well as fellowship session. So how are the 35 of us going to get our skills out there and, be ready for war? Well, that's why we're here. AMCT3 was created across the board to get those 35 trauma surgeons out to other sites. While there are still some in San Antonio, many of us are at these AMCT3 Bill Civ partnership sites. The two of us are here, and this allows us to collaborate and work alongside surgical titans here, and we learn from them, and we share our knowledge, as mentioned, to the civilian faculty and trainees here. There's a little picture of me and Colonel Young. He and I were the inaugural Army members of the program here. You can go Seattle Times and find that article if you're so inclined. A lot. So a little comparison of what Harborview is like compared to wartime. Harborview has over 7,000 trauma admissions annually, and that number is going up every year the past several years. 11,000 trauma activations. And we have a very large catchment area. As you know, we're part of the WWAMI program, and about 50% of our trauma admissions come from transfers, either from in-state or out-of-state, which is pretty comparable to the military evacuation routes. We have people on the battlefield, they get taken care of, and of course, ultimately, they get medevac to usually Germany, and then eventually stateside. So it's pretty comparable to having that large catchment area comparison to what we have to deal with. And then, of course, there's many gunshot wounds that we treat at Harborview. There's over 600 a year, and unfortunately, that's also increased over the last few years. And then we have many explosive injuries, usually related to certain holidays and birth. But this is the actual picture from the emergency department, I think, from the 4th of July this year. So, they're not exactly war wounds like IEDs and bombs, but they get pretty close. We've seen some pretty devastating injuries. So this is a direct comparison and correlation for us. Really gets us prepared for actually being on the battle. We have lots of variety, as you saw, the individual critical task lists that we have. We have to do all sorts of things, including campotomy, training activities, placing next fixes. We have sometimes direct and often indirect for collaborative exposure to procedures, which is great. Our past experiences during the global war on terror, case volumes can be pretty variable. Sometimes you're very busy, and sometimes you don't see the case for quite a while. That same goes for the role 3. So role 2 is the FRS, the Dr. Robinson mentioned, and role 3 is like the combat support hospital. Harborview, you can act as all 3 of these things, role 2, 3, or 4. 4 is your preventative care. And it's all dependent on what resources and what sort of casualty rate we have. But we might be out of blood in the trauma bay, which happens sometimes. We might have, we don't have any consultants available. There's in a deployed setting, it's usually just a general surgeon and an orthopedic surgeon. So if you need a neurologist or a vascular surgeon, well, guess what? Like I said, usually we have all the resources we need at Harborview, but sometimes overwhelmed. That can happen any institution at any time with mass casualty. So I often like to play like a mental exercise with my residents in the trauma bay, especially when we have time to huddle. Like, what if this? What if that? And it really it helps the military residents that come through sort of prepare for their future. But it's also I've been told it's very interesting for the civilian residents here too. They kind of give you a different lens into how we have to think a little bit differently to help maintain both our surgical and medical support. So being here it really enables surgical mastery, and that's it's immediately transferable to wartime. And that surgical mastery is through the high volume that we have, the amazing collaboration we have with the GME here, the partners I have, and my senior partners working with mentors. This high volume really hones our muscle memory, and we've mentioned this several times. This bi-directional informational transfer is amazing. We learn so much from everybody here. So we can impart what we can just deploy. So what's it like being deployed? For trauma surgeons and general surgeons, we usually spend anywhere from 3 to 6 months on our little camping trips. And depending on where you are, you may or may not have your feature couplets. So just some personal experience that I've had myself. I've been with a Role 2 or FRSD in Honduras, as well as Afghanistan at 2 different times, and then the Role 3 or Combat Support Hospital in Iraq. And there's a picture of me out in the desert somewhere. I guess it's during COVID, outside wearing a mask. Here we are. This is on my way into one of the theaters. This is the back of a C-130 cargo plane, which is what the Army uses to transport equipment and personnel. This is just kind of a cool picture because this is on my way into Afghanistan, and I just happened to be sitting with a giant shipment of whole blood. There are like 20 boxes of this. I think every box holds up to 50 units of whole blood. So just very interesting. They're sending in stuff that I'm going to be using, and they're sending in the person that hasn't used them. So the FRSD, as mentioned, is highly mobile. It's usually very austere. It's variable depending on what you have or don't have. There may or may not be running water. As you can see in this picture, the lighting is not very great. There's an air conditioner in this picture, but it didn't work. So this was a little resuscitation bay that we had set up, and I think this was the back of like a gas station or something. And this was our operating room, which you can see has a little bit better lighting. So we would take our, trauma resus room from this and go to the lighted area to perform whatever we needed to damage control measures. Touched on. This is a different Role 2 resuscitation bay. As you can see, highly variable, but this one is a little bit better lit, has a little bit better equipment. You can see that there's a portable X-ray, a little ultrasound in this picture, and this is about half of the team. FRSD is capped out at 20 people, but it's often split into 2 teams of 10. So this is, in this case, in Afghanistan, there were just 10 of us here. This is just an example of some of the injuries we saw. This was a AK-47 round to the right thigh in Afghanistan. And, the pertinent pictures here is intra-op and post-operative. But there's myself and the orthopedic surgeon operating on this person. Treated them for a vascular injury, had to ligate their femoral vein, and then, as you can see, that femur is shattered. So the orthopedic surgeon and I together put this external fixation device on, and then we had our team come and medevac them to our Role 3 hospital in Bagram, where no further vascular care was required, but they ended up getting care for their femur with a rod. So we have bidirectional information. We were able to hand off and hear about the post-op course. Here's another injury that's, you never know what's going to come across your trauma bay. This is a gunshot wound to the face. It was transmandibular, and I'm a trauma surgeon. I typically don't deal with face things, but guess what? Like I said, it's just an orthopedic surgeon and I. So ended up having to do a tracheostomy in the patient, and I actually Googled quickly how to do mandible fixation and talked to an ENT friend of mine stateside, and wired this person's jaw shut and took care of them. And they got the medevac. You never know what you're going to see. And of course, this is war. So war is not safe. So anytime you're deployed, you may have variable degrees of danger. But these are the pictures from Kandahar in Afghanistan, and there's some explosions here. That was from some rockets and mortars that enemy decided to fire at us. And then we were also nearby a firefighting team that we helped extinguish and evacuate casualties. So, you may have rockets lobbed at you. You may have IEDs that have direct combat. Never know. Here's a picture of the Role 3 or Combat Support Hospital. This is at Baghdad. It's a mini hospital. It's got more resources. It's got more personnel. There was about 100 of us there. We had a CT scanner. We had multiple subspecialists. So you can see on the left, it's just an entry point to our operating room, which was actually a tent. See on the other picture, our resus bays. We had a lot more stuff available. So here's our operating room. It's literally a tent. But it functions as any hospital would otherwise stateside. And so, these are relatively mobile and can be set up anywhere. But as you see in the picture there, we're doing a case, and I had the ophthalmologist strap in with me. He was available and wanted to help. So, in summary, I think the military civilian partnerships statewide, but specifically here, I can anecdotally say it's responsible for saving service members' lives. And I hope that this partnership keeps on going despite the uncertainty in the world. And I think that, you guys working with you has helped us save lives. We're going to look to you do the same if large-scale combat for come to our doorstep. So, and then, of course, the best part of deployment is coming home. That's a picture of me and my sons. Bring it back to the back. So thank you for your time. I'm going to turn it over to Major Roubik.
All right, final stretch, everybody. For those who don't know me, I'm Dan Roubik, Major Roubik, I guess. So thank you, Dr. Robinson, for providing nice background and kind of the history of the military partnership, and for Malloy for talking about kind of the current state of affairs. I want to talk about potential future, and following the military future, LISCO is one of the hot words, but anytime we're speaking in a public forum or with civilian groups, LISCO always comes up. In large-scale combat operation, then so we're going to talk about the implications of that and possible solutions for how we navigate that challenge. So also, no disclosure, these are my personal views, not the military necessarily. So we're going to talk about LISCO, what it is, how it differs from current warfare, and the picture that Dr. Malloy showed us there. We're going to understand the current future needs of the military-civilian partnership and how the NDMS helps with those needs. We're going to talk about how NDMS and LISCO interplay, and talk about how we could possibly use how LISCO might affect the whole range. So since July 4th, 1776, United States has known about 17 years. There's an old Prussian general named Clausewitz who famously said that war is an extension of policy, and it's a policy that the United States uses very frequently. So if history is the best predictor of the future, I have no reason to suggest that we are not going to continue to be at war, and that will take on many faces and have many needs. Obviously, the fates of war have changed over the years, from World War II, Civil War, and all those. Our casualty rate has drastically changed over the years, and how war conducted has drastically changed over the years. Where we're at now with the global war on terror, we're fighting non-state actors, extremist organizations, not necessarily land that we're holding, it's more ideology. One of the huge advantages that we've had is air superiority. When you have air superiority, you can get troops in, you can evacuate casualties, you can get supplies in, and that has allowed us to fight a very different style of warfare than what we saw at, say, World War II. It's really allowed us to achieve this golden hour that both those lectures have discussed, of trying to get soldiers to surgical care within 1 hour. And that has had tremendous results. We found that our died of wounds rate, which is when a soldier is injured and they're able to make it to a surgeon, we have about a 95% salvage rate. There's less than 5% mortality if a wounded soldier can make it to a surgeon. That's largely because of all these things here. So it's definitely a force multiplier when you have soldiers going into a dangerous space. We can tell them, you can make it back to us. We can keep you alive 95% of the time. And then also having air superiority, being able to surveil the area and have intelligence. But I have your Patriot missile system. This is how we defend against incoming ballistic missiles. I had the advantage of hearing one of those fire off when I was deployed in our defense. And then, of course, Air Force really tripped out. So again, you see this trend over time of lethality of war, where Iraq can't be. Compared to prior conflicts, this is almost as textbook. Now we're talking about large-scale combat operations. We're talking about if things heat up with Russia, Ukraine, we were to get more involved. If Taiwan battle, we were to put boots to the ground. Now we're talking about conflicts with near-peer adversaries, similar capability, large numbers of troops. There's an old mantra in the military that only the infantry can hold ground. So it's great to talk about drone warfare and all these things, but if it's a land conflict, drones can't hold land. So we're talking now about having thousands, tens of thousands, hundreds of thousands of troops involved in conflict, and with drastic implications for casualties. We're talking about multiple domains: land, sea, air. I know we all kind of laughed after the Space Force came to be because of how tricky it was, but it is a hugely important aspect to this. Our reliance on satellites, that picture on the bottom right, is an anti-satellite missile. And our satellites are how we are able to have communication in a stable fashion, how we're able to get GPS. Obviously, some of us get lost going across the street without GPS. Our air defense system are reliant on satellites. So keeping satellites safe is a huge critical important part of it. And then, of course, the information and cyber attack. Every branch of the military has some form of cyber countermeasures. And then massive casualties. Again, I have a graphic coming up. We've run models to try to predict what sort of mortalities we're looking at. I'll show that next. And then the unit size. Before, we're talking about platoon level with thousands of troops involved. Now, again, we're talking tens of thousands, hundreds of thousands of troops. And so you're currently predicting about 3,000 casualties a day if we're talking about a LISCO type situation, which the casualty care implication of that is just tremendous. Considering the kind of casualties we see now, it's just far and above and beyond what we're used to and are prepared for. So this was from TAX. They looked at, again, some of these predictions. Again, LISCO, we're looking at about 100,000 people involved. The most recent example we have that is somewhat comparable to LISCO is World War II. So we're thinking about that Normandy Beach style conflict with multiple troops, shoulder to shoulder. It's, again, what we're mentally preparing for. But of course, we're in the advantage of being in that position, trying to save lives. We're not there to talk about how to take lives in the medical side. And so that's our focus. We want to figure out, how do we respond to this? Does it gross increased number of casualties? And so the impacts for us is once we lose this air superiority, if we're in a spot where we can't get Air Force in and out as easily, now our role 2, which is supposed to be able to take care of soldiers for 72 hours and then ship them, might be expected to take care of them for a week or 2. And obviously we're going to have to adjust fire and how we initially supply those units, what field kits we have for first aid, and how we just conceptually think about field care. The triage is going to have to be different. Unfortunately, what used to be a expectant patient or a delayed, whatever, we're going to have to realize that if someone's going to tie up 20 units of blood, they might get triaged to expectant as opposed to someone that we could potentially try to salvage overseas. So it's a very difficult situation to be in overseas when you have a very limited supply and you have to be realistic on trying to help the most people with what you have. Blood product, we're always working on trying to find more shelf-stable blood product, blood substitutes, whether we're using freeze-dried plasma, those sorts of things, and trying to find the lightweight way of transporting these things. Everything that we have had to get carried out there. And then with still the damage control surgery model exists, then we might be in a situation where we're providing definitive care. Right now, from a burn standpoint, we're hardly doing any burn excisions overseas because as soon as you start excising burns, now you're having to transfuse a lot more, do a lot more regular dressing changes. So if at all possible, we try to temporize these burns and get them back to state. If someone's going to be with us for a week or 2, now we're going to have to discuss whether that's a viable strategy and whether we're going to be potentially wounding people more by delaying. And so how do we make this all possible? The NDMS, which is the National Disaster Medical System, which we'll talk about soon, has been, we'll talk about in greater detail, but that is certainly an option of how to get these soldiers in care. And then working with civilian and federal health systems. So right now, the current model, Dr. Malloy had a very similar slide to this. Our goal at every role of care is to stabilize a soldier enough to get him to the next role of care. Use the least resources possible so you can continue to help people. It's always easier to resupply the higher role you are. By the time you get to role 1, it's harder to get to those austere locations. So if we have 3,000 injured soldiers a day, and let's say 1,000 of them make it back, which is what we're currently trying to prepare for, where are they all going to go? If we're talking military casualties, obviously we'd like to keep them in the military system, but currently deployable beds in the military is about 4,000 beds. So if we are preparing for 1,000 casualties a day, and assuming we have no soldiers in any of these beds, that takes 4 days before we're saturated. Now that is the current state of affairs, and what we've seen historically is that we are able to adjust to the situation. During World War II, in comparison, we had 100,000 beds available in both the European Pacific theaters. So 4,000 now compared to 100,000 then. But also in World War II, we started off with 1,200 docks, and by the end of it, we had over 50,000. So again, whenever push comes to shove, our nation is resilient. We do find a way to make these things happen, but it would definitely require a lot of growth and adaptation. That's the military side. Now the civilian side, this is from the American Hospital Association. Other estimates are far lower than this, what I'll say, but based on publicly available information, I'll say there's about 900,000 beds available. If you look within the NDMS, a little bit less than half of that. So we have a little less resources to work with. But all that's to say, if you had to design a system and you were told you have 1,000 injured people, American citizens coming back to the United States who are injured, if our military beds are full, then the civilian beds are the next logical option. So how do we leverage these civilian resources? And that's where the National Disaster Medical System comes. This is the product of a Ronald Reagan era work task force. In 1981, Ronald Reagan came into office and he identified the need at coming off the tails of Vietnam for civilians to have a system to take care of military casualties. And after about 3 years of them putting their heads together and discussing it, they developed the NDMS. The primary mission of the NDMS, when it was originally conceived, was to provide medical evacuation definitive care for the U.S. for military casualties returning from an overseas war. That is the primary mission. It's very military focused. Its secondary mission was to supplement state and local medical resources during disasters and emergencies. So the way that they do this, again, is a federally coordinated system. Again, it is at the federal FCC level that supports medical response, national disaster, interplays with FEMA at many times. It has these groups called DMAT, which are these rapidly deployable medical groups that can provide medical care to certain regions. Think about like COVID, whenever we're having all these outbreaks, you get these little pop-up test stations and vaccination stations.
the NDMS help facilitate many of those. They can help with evacuation and tracking in cases like Hurricane Katrina, try to figure out where these casualties are going, and also mortuary affairs in cases like that. They do have a definitive care network of hospitals. It used to be over 1,600. Whenever I was refreshing my numbers yesterday, looked like now it'd be over 1,800 is quoted at sometimes. So all across the nation. And the difference between the NDMS and what we have with our local group is we are able to locally reallocate patients within Washington, but the NDMS can transport patients across state lines if that's what is needed. And again, they also have pediatric centers of excellence in the East Coast, West Coast, and so they have multiple facets, multiple teams that facilitate their mission. Again, all over the nation, this is kind of an outdated map, but large major hubs, the aerial port of debarkation, they're usually military based. This is they are all based either out of VA or DoD level, DOW level facility. And it has local, we do have local NDMS groups. So Harborview, here you can see the Central District of Harborview Medical Center, King DMCC, is one of our local hubs that helps communicate with the NDMS to facilitate the NDMS mission. So an example of this, so this is not necessarily the NDMS. I'm speaking with the Deputy Chief of the NDMS for the Army yesterday, and he wanted to specify that this was our local group that facilitated this mission. Whenever COVID hit, we had a nursing home outbreak of COVID, and all the patients ended up going to one hospital with overlay. And apparently after they were just completely overwhelmed, they started putting out calls to say, hey, we need more ventilators. Well, realized maybe just giving them all the ventilators and all the patients wasn't the best option. And maybe we can find a means to redistribute these patients to not overwhelm one hospital system. And so as a result of that, we helped make our own medical operations center that's mobilized, which is this Washington Medical Coordination Center that works with the Disaster Medical Coordination Center, which is more of a national level, to help facilitate the mission, try to realize what local resources we have to allocate all those patients. It was a pretty small, slim Sigma 6 model there. We had the one RN that was on duty for 24/7 and one physician as backup, usually the medical director that helped facilitate the knowing what resources were available and allocating them. And they'd conduct routine briefings to realize what hospital beds were available, what needs were in the region. They would routinely update at the national level to see if there were other options available, and then try to figure out how we could get these patients the best care they needed. And that's what really worked. And naturally, it worked really well. So then it was defunded 2 years ago. So it's not here anymore. I say it's just for historic benefit. But if we did need to leverage these resources again, at least we do have precedent to bring this off of. Looking at other times at the NDMS on a national level, that was an example of a local scale. When we look at the national scale, the Hurricane Katrina, Haiti earthquake, 2010, California wildfires, notice one thing about all these examples. It had never been utilized for military purposes, which again was its primary mission, which then makes us ask, can the NDMS actually serve its primary mission? Looking at all the available literature available, there are some concerns as to whether or not the NDMS can serve this mission. Enter the National Center for Disaster Medicine and Public Health. This is a group that is outside the NDMS. It is based out of USHS, the Uniformed Services University of Health Sciences, out of Bethesda, Maryland. It is more of like a think tank group. That has been a group that has been asked by the NDMS to conduct some research studies and run some numbers for them. But they have been asked to kind of head up this NDMS pilot program. Again, the deputy chief of NDMS asked me to specify this is not part of NDMS. This is very much the National Center for Disaster Medicine and Public Health leading this. But they're trying to conduct research, and so they're the think tank, try to find ways to utilize the hands-on capabilities of the NDMS to facilitate this mission of taking care of all these casualties. And the overall goal is that they want to be able to transport and allocate 1,000 injured soldiers a day for 100 days, which is admittedly probably maybe an unrealistic goal just from an FCC being able to transport all of these patients in general, but that is the goal that they're trying to prepare for given the predicted need. So what does this mean for all of you? Obviously, Harborview Level 1 Trauma Center, if we don't have all the beds available, we might be reliant on other hospitals within the NDMS system. This is a map of kind of the command structure. that the Army utilizes. One thing I'll focus here is the Indo-PACOM region, which is, again, where Taiwan would be. Notice where everything kind of funnels back from the state side. East Coast would be kind of the main hub of any casualties getting to the United States. And so if you have people who are injured, especially the more severe, more acute, probably not prudent to try to transport them to San Antonio, for example. So we might be seeing a large number of these soldiers here. So in the case of overwhelming casualty, especially with Indo-PACOM, all available beds must be utilized. And what has been previously discussed, first off, again, the head of NDMS wanted me to specify these would not be acute trauma. By the time they make it to stateside, they would not be within the first 24 hours. They need to be somewhat stabilized traumas if we felt the need to get them back to the United States. So we're not asking random hospitals to take care of acute trauma. But if they are trauma-related, we still would like to take care of them at Harborview. That is our mission. That is our patient population. And so to enable Harborview to take care of these patients, we discussed previously is diverting non-trauma patients from Harborview, which we've done before. We've been on BLS Divert. I'll get calls for a lap poli to be transported from another hospital. And we say, maybe we can hit that to any other hospital that has general surgery capability. So we could take care of trauma patients. We may need to vacate non-trauma patients from Harborview. And then if push comes to shove, we're completely overwhelmed with war-related injuries, we may have to utilize non-trauma hospitals for trauma patients, i.e. Mott Lake, Silver Lake, hospitals like that. What has been discussed is that if these soldiers came in, they'd probably go in through Boeing Field, which would be a re-triage point. But then we have some unique issues here. If we were, for example, in war with China, where do a lot of our supplies come from? And so we could have issues with supply chain. Dr. Malloy and myself might be deployed, so we might be running a little slimmer in terms of our local resources. And then obviously cyber attacks, and we're dealing with very complicated enemies with a lot of resources available. And so could lead to a lot of vulnerabilities in that regard. But fear not, help us around. Of course, if you're at a hospital that is now taking care of war-related injuries, and you're not doing trauma, of course, it's always Occam with our fund of knowledge built within the University of Washington system. The Joint Trauma System, again, outside NDMS, is it's like our QI for war-related injuries. And they have a lot of clinical practice guidelines online that anyone can access. So if anyone's ever curious what our standard of care for treating war-related injuries overseas is, you can always just type in JTS DPG, and you'll have all of them available to you. There's also narrated PowerPoint presentation, so you don't even have to read it yourself. You have one of our faculty from BAMC reading them to you. And then also the integration of trauma societies within the military planning discussion. I understand that whenever there's an ACS meeting, AAST meeting, it's always been a topic of discussion of what we do and how can the civilian organization help in these times of need. So in summary, let's go present unique challenges for overseas and locally. The NDMS is a great starting point as to how we can help leverage resources to take care of these casualties and address some of these issues. And then military civilian integration is mutually beneficial. So thank you, first off, too many people made the presentation possible. Department of Surgery, Dr. Boulderwood, Tony, for providing a lot of resources that help gives a great starting point for our entire division of trauma, burn, critical care. OTSG provided us a lot of help, especially yesterday, as Dr. Robinson alluded to. Cynthia Berrigan, Hillary Battles, who are our point people for our AMCT3. Andrew Goodrich, who again is the deputy chief of the NDMS for the Army. It's kind of cool to be in a position where you get to speak to kind of the head honcho in the nation for the program, who just casually talked to me on his drive home from Washington State. All the people at Harborview Medical Center in our departments, and of course many more. So are there any questions?
So I just want to start thanking Drs. Bryce, Malloy, and Roubik. I learned so much from this presentation. This was spectacular, and you covered a huge area. I want to thank you for your service. So thank you for what you do. And we are very proud of the military-civilian partnership here at the University of Washington at Harborview. I'm still thinking about the photo that we had in 2019 that you showed up there. And I know how well things are going. And so I guess my question is, where are the weaknesses? And I'm thinking about on our side, at UW, at Harborview, are there things that we can be doing uh, to be better in terms of our part of the partnership that you see?
Parking is the only
Yeah, that's probably true for everything.
We are in front of us right now is the funding issue. Yeah. And a significant amount of funding. It's pocket change from the military or Congress, but it does support the administrative functions that the Army requires. What happens after this year in terms of administrative things, we're not sure. If you talk to the Office of the Surgeon General, they highly value these programs, and there may be subcontracting and third-party contracting. But in the end, we're not really sure. It's going to be a time of tightening our belts for everybody as Medicaid, Medicare funding changes. But I think we all value these programs, and administrative lift may be on our shoulder.
Sorry, says to steal and do a follow-up question then. Where is this on the advocacy side? So what are the things that we should be talking to our Congress people about to help support the program?
Yeah, if you haven't been there, the American College of Surgeons had Surgeon's Voice. It sounds like it's not going to help. No, it really helps. And I think as yourself and other people get in front of your Congress, of your senators, advocacy days, these are things that need to come up. And again, we're only talking about a couple $1 million. So in the greater scheme of things, the dollars are pretty small, but there has to be a sense of awareness. And so the American College of Surgeons, the COT, the AANC, these are all big trauma organizations, have a large voice when they talk to Congress about these things and reenacting the Mission Zero Act. And that's what we're really focusing on right now. But it's a groundswell. It has to come not just from the trauma community, but it's going to have to come from all of our societies and individuals, like I mentioned at that very end. So I just really support the idea of going to the American College of Surgeons site, look at the surgeon's voice, and you'll see there's an opportunity to lend your name to this support. Great point. Thank you, Julie.
Gentlemen, my name is Madhuk. Thank you for your talk, and makes me very proud to be a retired Army surgeon. Saw the progression of this over my 20-year career to where we have Army surgeons in civilian trauma centers and really maintaining readiness at the tip of the spear, if you will. Two points. One is that one of the challenges I see is a level of preparedness, both as a military and as a society, for the level of casualties that we're going to see in large-scale combat operations, where the triage will no longer be for survivability, but rather who can we return to the fight. And so it's a very different mindset in terms of triage. And I've just posed the question as the local trauma think tank: how do we train a generation of providers that may have to face that decision making? So that's good question one. Second, shameless pitch: we are trying to rebuild and reinvigorate our simulation collaboration with the military in Madigan. So there is a symposium actually next Friday. That is the WISH Symposium, which will have a focus session on military UW collaboration and simulation. So the work is ongoing, and so I just wanted to mention that as well.
Thank you very much. I'll start then, and I'll lean on my partner here. The way we teach trauma care for our trainees, ATLS, World Trauma Care courses, like you're 100% right, will not apply very well if this were all to happen. And I think what our military partners are alluding to is the idea that if trauma needs do extend it to the civilian population, it's going to look a little bit different than on Friday night at Harborview. I think we're going to have people that are more stabilized, but we're still going to need the bed. We're going to need the acute care bed and the critical care beds, and then add some burn to that. And we have a real shortage and capacity issue. So you're 100% right. I think we need to start having those conversations of just in trying training. We did with COVID. It wasn't great, but we had mechanisms to push out information, guidelines, et cetera. And I think you're going to have to see that from our trauma societies, our surgery societies, in any sort of shape or form to bring that education to them. But you're 100% right. ATLS is not going to apply to these patients coming back.
But yeah, I do think these military partnerships are essential for preparedness and readiness within the than soldiers and active duty surgeon population. One other mechanism for preparedness that the NDMS in our region has pointed to us, that I should have mentioned it. So our big group that responds to the NDMS and reports to the NDMS is the FCC Puget Sound. And they're going to be conducting an exercise in the area in April of 2026 for patient movement and trying to simulate how we would get people moved around and everything like that. But so I think working with the NDMS, having these military partnerships to try to improve readiness at that level, at the end of the day, I don't know if anything will prepare you other than the moment itself. And what we've demonstrated in the past is we are able to respond and adapt and having a motivated group of soldiers. And so luckily these discussions are happening.
Yeah, one more comment, just to from an advocacy perspective, the other thing that you should be advocating for is funding for the Washington Medical Coordination Center that was referenced, that we set up during COVID, and we actually ran it until July of this year with funding, and then we lost the state funding. But that is a one-stop shop for us to coordinate and level load patients among hospitals across the entire state. And I think the scenarios that we're talking about with LISCO, Harborview is not going to be the only place where these patients are going. We'll take as many as we can. Madigan will take as many as they can, but they're going to go everywhere. And we need a system in place on the ground locally to help us understand what the situational awareness is, what the bed capacity is in all our hospitals, and then a mechanism to level load patients and know where to send them, where they can get the best care. We had it during COVID. We've lost the state funding. We're strongly advocating for that return of funding because I think it's going to be critical to our local response. We are one of the NDMS pilot sites, so we have a group that's actively doing gap analyses and pointing out where these holes are in our local system. But make no mistake, this is going to impact every single surgeon in our community. Every one of you is going to be impacted if we have the LISCO event. And we want to be as prepared as we can locally to be able to deal with the influx of casualties. So lots of work is going into this. But I think from an advocacy perspective at the state level, the WMCC funding is the other really key critical piece of this.